Welcome to Pathology Central Key Concepts. The topic of this video is inflammatory bowel disease. There is a lot to unpack, and so we have one objective and one objective only, to compare and contrast the clinical features and pathophysiology of ulcerative colitis and Crohn disease. So when we talk about inflammatory bowel disease, what we're referring to is in genetically susceptible individuals, they can have an aberrant host immune response to the intestinal microbiota, which leads to a chronic inflammatory condition. There are two disorders within this category. One is ulcerative colitis, which is limited to the colon and rectum, and in which the inflammation is usually limited to the mucosa and submucosa. By contrast, Crohn disease may involve any area of the GI tract, and the inflammation and inflammatory response is typically transmural. I'm going to show you an image from Robbins and Kumar Basic Pathology 11th edition to provide a framework. We're going to go through all of this in a stepwise fashion, but I think it's nice to have a concept of how these two compare and contrast. So as I mentioned, ulcerative colitis is restricted to the rectum and colon, and furthermore, you'll appreciate that we have continuous involvement. We contrast that with Crohn disease, in which you can see anywhere in the GI tract is involved, and that instead of continuous involvement, we have interspersed areas of healthy mucosa with these lesions, and so these are referred to as skip lesions. This cross-sectional image of bowel wall shows you some additional differences between these two diseases. The bowel wall in Crohn disease is quite thickened. This is due to hypertrophy of the muscularis propria, but also because of this transmural inflammation, we have an inflammatory infiltrate, we have edema, we have fibrosis, and in response to this, a mesenteric fat will begin to wrap around the bowel wall. This is referred to as creeping fat. In Crohn disease, we tend to have these deep linear ulcers or fissures that can actually perforate, causing disease within the abdomen, or can form a fistula tract to another organ. Now, if you look at this cross-section of bowel involved by ulcerative colitis, you'll see that by contrast, the wall here is quite thin because we don't have that transmural inflammation and the response to it, fibrosis, edema, etc. We don't have these deep fissures. We have these broad-based ulcers, and we have these little pseudopolyps, which are little islands of regenerating mucosa that bulge into the lumen. Now, this is a visual way of looking at this. I'm also going to give you a table, and I would encourage you to use this as a way to compare and contrast. I'm not going to read this aloud, but you can use this for your review, and we will address this again at the end of the video. So here we're looking at how these two diseases are different. Let's talk about what they have in common. So clinically, both of these diseases tend to arise in teens or individuals in their early 20s. Both of them are characterized by diarrhea, which in the setting of Crohn disease tends to be intermittent attacks of mild diarrhea associated with fever and abdominal pain. By contrast, the diarrhea that we see in ulcerative colitis is frequently bloody with associated stringy mucoid material, and abdominal cramps and pain are characteristic of this entity. Interestingly, while smoking increases the risk of Crohn disease, it is associated with either no change or a slightly reduced risk of ulcerative colitis. Now, both of these diseases can have a variety of extraintestinal manifestations, which I've listed for you here. And I'll talk briefly about primary sclerosing cholangitis. As you recall, primary sclerosing cholangitis is associated with inflammatory bowel disease. And what we know is that of patients who have primary sclerosing cholangitis, a great proportion of them have inflammatory bowel disease. However, a large proportion of people who have inflammatory bowel disease do not have primary sclerosing cholangitis. So the arrow goes one way but not the other. And then another factor that we'll come to at the end is the increased risk of colon cancer in individuals with inflammatory bowel disease. So I'm going to put here just again a list of the clinical features in a tabular form. I'm going to cover this again at the end once we've worked through it. I'll cover a few things here. As I mentioned, Crohn disease can affect the small intestine in contrast to ulcerative colitis. And when we have small intestinal involvement, we can get fat and vitamin malabsorption. I also want to point out here, frequently in textbooks it'll say something like the risk of primary sclerosing cholangitis is higher in ulcerative colitis than in Crohn's disease. But as you can see here, these figures from the literature show that they're really the same order of magnitude, so please don't fall into the trap of thinking, oh, my patient has Crohn's disease, I don't have to worry so much about primary sclerosing cholangitis. Think about this for all of your patients with inflammatory bowel disease. So now we're going to turn to the pathogenesis, beginning with genetic factors, then talking about aberrant mucosal immune responses, intestinal epithelial dysfunction, and host microbe interactions. So let's begin with the genetic factors. We know that there's a genetic component because we have familial associations. So if one family member has it, there's an increased risk for other members of that family. A susceptibility factor has been identified in Crohn's disease. That's the NOD2 gene. The NOD2 protein binds to intracellular bacterial peptidoglycans and stimulates the NF-kappa B production. And we know that defective NOD2 is less effective against bacteria, allowing bacteria to penetrate the intestinal epithelium. This leads to inflammation. And then through looking at genome-wide association screening, we've identified a number of different families of genes. Some of them are in the autophagosome pathway, which has to do with the host cell response to intracellular bacteria. Now this is where it really gets interesting, is the abnormal mucosal immune response. Now we know that inflammatory bowel disease has to do with a dysregulation of the immune system, because if you suppress the immune system, patients tend to do better. So we know that immunosuppressive drugs and immunomodulators, such as antibodies that inhibit tumor necrosis factor, IL-12 and IL-23, improve disease for patients. And I'm going to talk about epithelial barrier dysfunction in a moment, but when you have that, microbial antigens enter the lamina propria and they're picked up and processed by dendritic cells. Dendritic cells will then present those and they will secrete a number of cytokines. Some of those cytokines include IL-12 and IL-23, which will stimulate CD4 positive C cells to differentiate into Th1 and Th17 cells. These cells will then work to activate macrophages, recruit neutrophils, and will release additional pro-inflammatory cytokines such as tumor necrosis factor. Dendritic cells can also release IL-8, which attracts neutrophils. So you can see we're creating this sort of cytokine soup, which is very pro-inflammatory. We also know that defects in regulatory T cells can be seen in inflammatory bowel disease, particularly defects in T cells that produce IL-10. And we know about this association because in rare patients who have a mutation in IL-10 or IL-10 receptor genes, these patients tend to have severe early onset colitis. Now I'm going to show you an image that covers all of the pathogenesis, but I just want to focus on the altered immune response because I just gave you this whole long list of interleukins and cytokines, and I think it's good to look at it while it's still fresh in your mind. So we have our microbiota here. Bacterial components come through, perhaps a little bit of barrier dysfunction. The dendritic cell scoops those up, presents it to the CD4 positive T cell, and the dendritic cell says here some IL-23, differentiate along Th17, secrete some IL-17, recruit some neutrophils. The dendritic cell is also going to secrete IL-12, which is going to take us down to the Th1 pathway. We'll begin secreting interferon gamma, stimulating our macrophages, which will be releasing tumor necrosis factor. And then dendritic cells also will secrete IL-8, which can also be released by the epithelium, which is going to bring in more neutrophils. Okay, now let's talk about epithelial dysfunction. So if you think about it, epithelium is this layer between the microbiome in the intestinal lumen and the lamina propria below. And if you have defects in the intestinal epithelial tight junction, then it's easier for those bacteria to enter into the lamina propria. Now, defects in these tight junction barrier functions co-segregate with disease-associated NOD2 alleles. So that was one way that we recognize the epithelial dysfunction. And then there's a lot of experimental evidence that shows that barrier dysfunction activates innate and adaptive mucosal immunity and sensitizes subjects to disease. This brings us to our final issue, which is changes in the microbiome. So as you're aware, there's inter-individual variation in the composition of the microbiome, and that a significant component of fecal matter is composed of our microbiome. Early indication that the microbiome was involved in the pathogenesis of inflammatory bowel disease is that children who are given antibiotics at an early age have an increased risk of inflammatory bowel disease. We also know that there are differences in the density, so the amount of species of or the amount of the various bacteria in the microbiome, as well as the composition. So what is the variety of species that we see in the microbiome? And we know that there are differences in density and composition in patients with inflammatory bowel disease compared to individuals who don't have inflammatory bowel disease. But we don't know whether this is primary. So for example, does the microbiome drive inflammatory bowel disease by certain proteins or components of these particular species? Or is it secondary, that this inflammatory milieu is what is driving a change in the microbiome? We do know, however, that bacteria appear to contribute to the dysregulated immune response. And there have been some clinical trials looking at fecal microbial transplant for inflammatory bowel disease treatment. And it seems to be more effective in ulcerative colitis than Crohn disease. Okay, so here is our image again from Robbins and Kumar, Basic Pathology, 11th edition, which puts it all together, our microbiome, which comes through here, the bacterial components scooped up, the cytokines we discussed before. And keep in mind is that as we get injury to this epithelium, that's going to increase the influx of bacterial components. So the ulceration and denudation that you're going to see histologically are increasing the opportunity for these bacteria to get into the lamina propria. So what do we see grossly with Crohn disease? Now that we've talked about what the diseases have in common, we're going to split apart and do Crohn disease and then ulcerative colitis. So as already mentioned, it may occur anywhere in the GI tract, most commonly the terminal ileum, ileocecal valve, and cecum. However, about 40% of patients have disease limited to the small intestine, 30% have small and large intestinal disease. As mentioned, we have skip lesions, so healthy intestine interspersed with affected intestine. And this repeated cycle of inflammation and regeneration and healing can lead to strictures. So these are areas of narrowing, and patients can have an obstruction secondary to that. These ulcers that form are deep ulcers, so they can form fissures, as I'll discuss in a moment, and they tend to be aligned along the long axis of the colon. And this regeneration and repair with subsequent injury leads to a cobblestone appearance of the mucosa. These fissures can lead to fistula tracts to other organs or frank perforation. And the thickening of the bowel wall is due to submucosal fibrosis, edema, muscularis propria hypertrophy, inflammation, and edema is so important I mentioned it twice. This thickens our intestinal wall, which appears even thicker because this extensive transmural inflammation is going to lead to creeping fat. So I just discussed the gross morphology, but I'm going to show you an image of histology because it actually covers what we want to see. So this is a very low power view, but it covers everything, well not everything, but it covers a lot of what I just mentioned. So here you can see an area of healthy intestinal mucosa. Here's another area of healthy intestinal mucosa, and then here's the ulceration in between. So this is a skip lesion. Another thing that you can appreciate at this power is this thickening of the muscularis propria. So you can see here it's quite thin, quite thickened here. And we also have transmural inflammation. So you can see these lymphoid aggregates that are scattered all the way through the bowel wall. And there are actually some things in here which are quite interesting, which we'll look at when we discuss the microscopy. Okay, so back to our gross image. This is a stricture of the small intestine where you can see that the lumen is significantly narrowed compared to the lumen on either side of this particular lesion. Here you can see the gross appearance of the mucosa with these linear ulcerations that have been likened to bear claw scratches. And it has a bit of a cobblestone appearance as well. Now, this is an image of creeping fat. So here we have a section of bowel. This is the attached mesentery, and the fat is wrapping around, creeping along to the anti-mesenteric side. This is going to substantially thicken this section of bowel. So what do we see histologically? There are a number of things that we see both in Crohn disease as well as in ulcerative colitis. So in both of them, we can see crypt abscesses, cryptitis, crypt destruction. And because of these cycles of injury and repair, in both diseases, we see crypt architectural distortion, and the chronic injury can lead to epithelial metaplasia. But something that we see in Crohn's disease that we do not see in ulcerative colitis are non-caseating granulomas. These are seen in about 35% of cases, and we don't actually, as pathologists, spend a lot of time looking for them because we can tell by looking really at that transmural inflammation. That's going to be a much better indication for us that we're considering Crohn's disease as opposed to ulcerative colitis. So this is an example of a crypt abscess. So you can see here that we have surface ulceration with loss of the goblet cells. This particular crypt is in the process of being destroyed, as is this little section here. And this one, which has a crypt abscess, you can see that the lining epithelium is quite attenuated with this little collection of neutrophils in the center. And this can eventually be destroyed. I'll show you an example of crypt architectural distortion when we look at ulcerative colitis. And here, this is beautiful. This is your granuloma. This is the classic granuloma we see in Crohn's disease. You can see that it's non-caseating, so there's no central necrosis. It's composed of epithelioid macrophages that form this round structure here in the lamina propria. So let's talk now about how we treat people with Crohn's disease. So because of these strictures and fistulae, the individuals may require surgical resection, and there's a risk in Crohn's disease of recurrence of disease at that area. So if you go to the clear margin, because this is going to be a skip lesion, and you go to the healthy intestine on either side, and you join that, you can get recurrence of disease in that site. Colonic disease can result in iron deficiency anemia, which you can also see in ulcerative colitis. And as I mentioned earlier, small intestinal disease can lead to protein loss and malabsorption. We treat these individuals with anti-inflammatory agents, so corticosteroids, anti-tumor necrosis factor antibodies, and biologic therapies like antibodies against cytokines and cell adhesion molecules. Now, because you have this chronic inflammation that is remitting and returning, we have to think about the possibility of neoplasia. Because as you recall from the neoplasia chapter, chronic inflammation is a setup for dysplasia leading on to malignancy. So individuals with inflammatory bowel disease, both Crohn's disease and ulcerative colitis, require surveillance endoscopy, and we'll talk about that in a moment. But let's turn, before we move on to malignancy, to the clinical features of ulcerative colitis. Again, teens and early 20s, as I mentioned before, bloody diarrhea with stringy mucoid material, cramps and abdominal pain. Similar extraintestinal manifestations as what we see in Crohn's disease, and like individuals with Crohn's disease, increased risk of colon cancer and primary sclerosing cholangitis. Many of the same medications that we use in Crohn's disease work just as well in ulcerative colitis, although not entirely, so there's probably some difference in the pathogenesis of these two diseases. Individuals with ulcerative colitis, if they are refractory to treatment, they may undergo a colectomy. However, medical management has advanced to the point that we don't see this as commonly as we used to. And again, we'll use anti-tumor necrosis factor antibodies and immunosuppression. So grossly, again, it's going to be the colon and the rectum with continuous involvement and no skip lesions. We can see broad-based ulcers or just this general granular appearance of the mucosa, which is due to this chronic injury, which leads to mucosal atrophy. And yet in other areas, we can have islands of regenerating tissue, which lead to these pseudopolyps. Something we see in ulcerative colitis, which we don't see in Crohn's disease, is damage to the neuromuscular function, which can lead to colonic dilation and something called toxic megacolon, which we see in ulcerative colitis, not Crohn's disease. So here we have two images of the gross morphology of ulcerative colitis. Here we have a total colectomy. The rectum would be here. We extend over to here, and here's just a tiny amount of ileum. Here is the cecum. And it's a little difficult to make out because of the coloration here, but you essentially have this erythematous granular mucosa until we get right to this point, and there's an abrupt transition to normal mucosa. So no interspersed healthy mucosa, it's all pathologic. And you can see this abrupt transition here when we look at this higher magnification, this sort of granular erythematous mucosa, and there are little pseudopolyps that are dotting this. In contrast, here we have the healthy mucosa right here. Now, if you do have pancolitis, You can get the inflammatory cytokines can actually backwash into the ileum. So this is called backwash ileitis, and that's really the only time you see small intestinal involvement in ulcerative colitis. Now, as I said, the histology is very similar to what we see in Crohn's disease, with the exception of we lack granulomas. And again, inflammation will be limited to the mucosa and superficial submucosa, and we can have broad-based ulcers and pseudopolyps. I'm going to show you a beautiful example that shows you these features. So this is a very low power view of ulcerative colitis. You can see right away, and you don't need to hold the image in your mind because I'm going to do a compare and contrast for you in a moment, that we don't have that hypertrophy of the muscularis propria, which we saw in Crohn's disease. We do have these little pseudopolyps interspersed with areas of ulceration, and we don't see inflammation anywhere other than in the mucosa and superficial submucosa. So it's just this narrow band up at the top. Now, I mentioned that crypt architectural distortion can be seen in both Crohn's disease and ulcerative colitis. The example that I have for you comes from ulcerative colitis. You can see here, this is what a normal crypt will look like a normal, like a little test tube. But you can see here we've got some branching. Branching here, and this is due to the cycle of injury and repair. Here is just another example of it where you can see these very odd shapes and branching. Okay, so let's do a compare and contrast. If you were to see something like this, knowing nothing else, you'd be able to tell which of these is ulcerative colitis and which is Crohn's disease. So here you can see that thin bowel wall compared to this very thickened wall, which has got a lot of edema, inflammation. This is our Crohn's disease. You'll also know it's Crohn's disease because you can see that this is small intestine. You can see the villi here. We have our chronic inflammation here, hypertrophy of the muscularis propria, and edema here in the wall. By contrast, superficial inflammation, no hypertrophy, no inflammation going through the wall. So now that we've gone through it, I hope that you look at this figure and with fresh eyes and it all makes sense to you because we've seen everything that we've discussed here. And now I'm going to just finish up with a table, which is again has the clinical features on the left as well as the macroscopic and microscopic features. Now's the moment when we're going to talk about malignant potential. Okay. Now, the real issue for us is going to be looking at colonic adenocarcinoma. So obviously, if we're talking about colonic adenocarcinoma, you only see it in Crohn's disease when the colon is involved. So let's talk about colonic adenocarcinoma in inflammatory bowel disease. So it's really associated with three factors. One is the duration of disease. So if someone initially presents with inflammatory bowel disease, it takes about 8 to 10 years for that increase in risk to occur. So you're not going to whisk them into the endoscopy suite right at diagnosis for surveillance. You'll whisk them in there so you can make the diagnosis. A second factor is the extent of disease. So we know that individuals with pancolitis, so ulcerative colitis that affects the left, right, colon, the entire colon, are going to have a higher risk of colonic adenocarcinoma than left-sided disease. And that makes sense. You have more mucosa, which is exposed to these cycles of inflammation. And as I mentioned already, we see colonic adenocarcinoma in Crohn's disease only when it involves the colon. So it's small, if it's small intestinal Crohn's disease, you don't have an increased risk of colonic adenocarcinoma. The third feature will be the severity and frequency of the inflammatory response. So inflammatory bowel disease is an intermittent disease that will remit and then recur with relapses. And depending on how severe the disease is and how frequently you have those relapses, that is also associated with increased colonic adenocarcinoma. So increased severity, increased frequency increases risk of colonic adenocarcinoma. Now, there's been a lot of debate about the pathways of adenocarcinoma in inflammatory bowel disease compared to sporadic adenocarcinoma, and it appears there are some differences. So, as you'll recall, APC and KRAS mutations are associated with sporadic adenocarcinoma, a little bit less common in inflammatory bowel disease adenocarcinoma, where we tend to see early mutations in TP53. Sporadic colonic adenocarcinoma tends to have late mutations in TP53. So because of the risk of colonic adenocarcinoma at about 8 to 10 years, you'll begin doing surveillance endoscopy on your patients. And one of the things to keep in mind is that, as I showed you, you can get these areas where you have atrophic mucosa, and we can get dysplasia that arises in these flat lesions, as opposed to in sporadic adenocarcinoma, we typically associate adenocarcinoma as arising in polyps, so in adenomas. the adenocarcinoma sequence. So it takes a very experienced endoscopist to recognize a flat lesion that could be dysplastic. And I'd just like to mention, although we're focused on colonic adenocarcinoma, individuals do have an increased risk of small intestinal adenocarcinoma if they have Crohn's disease in that location. Now, we don't know exactly how common this is because we don't know how many patients have small intestinal Crohn's disease that we're simply not picking up. So we don't know what our denominator looks like. But I would like to share with you just a beautiful image again, which shows you everything you need to see. So first of all, we know we're in the small intestine because we have villi. We know we have a cancer because we have these disorganized atypical glands that are invading down into the muscularis propria, which is never good. And then here we have a fissure, which is associated, as you know, with Crohn's disease. So this is a small intestinal adenocarcinoma arising in the setting of Crohn's disease. So I'm just going to finish up with a couple of questions for you to do your own compare and contrast. How do the gross and microscopic appearances differ between Crohn's disease and ulcerative colitis? What are the extraintestinal manifestations of those two diseases? And why is surveillance endoscopy necessary in these patients? As always, I'd like to thank you for your time. I hope you have found this useful.